name is Hugh, and today I'm presenting thyroid cancer with my teammate Yaji. Let's start with some basic information of thyroid. The thyroid gland is located in the anterior neck, spanning between C5 and T1 vertebrae. Thyroid secretes hormone that acts through the body, controlling metabolism, growth and development, and body temperature. Thyroid cancer is a type of cancer that starts in the thyroid gland, usually on one side. It starts when cells begin to grow out of control. There are two main types of thyroid cancer. They are papillary thyroid cancer and follicular thyroid cancer. And three other less common thyroid cancer they are medullary thyroid cancer, anaplastic thyroid cancer, thyroidsarcoma, or lymphoma. The two main types of thyroid gland cancer originate from thyroid follicular cells. However, there are some differences between two. Papillary cancer. These cancers tend to grow very slowly and usually develop in only one lobe of thyroid gland. Even though they grow very slowly, papillary cancer often spread to the lymph node in the neck. Even when these cancers have spread to lymph node, they can often be treated successfully and are rarely fatal. Follicular cancer is the next most common type, making up about 1 out of 10 thyroid cancer cases. It is more common in countries where people don't get enough iodine in their diet. This cancer usually do not spread to lymph node, but they can spread to other parts of the body, such as lungs or bones. The prognosis for follicular cancer is not quite as good as that of papillary cancer, but they are still good in most cases. You can see from the image on the right side, it shows the difference of two types of cancer cell under a microscope. The symptoms of thyroid cancer include a lump in the neck or throat, difficulty breathing or swallowing, a swollen lymph gland in the neck, a hoarse voice, vocal cord paralysis or dysphagia, often symptoms of having a thyroid cancer. Exposure to inject radioactive isotopes and radioactive fallout also poses a cancer risk, especially for young children. Having a parent with multiple endocrine neoplasia, type 2A or 2B, or medullary cancer also increases the chance of having a genetic mutation that causes thyroid cancer by as much as 50%. Women are 2 to 3 times as likely as men to develop thyroid cancer. Those women who has their last pregnancy occur later than the age of 30 are also at a great risk. Being a white and Asian make them more susceptible to having thyroid cancer. Other controllable risk factors include dietary iodine deficiency, ingestion of goitrogen or cruciferous vegetables such as cabbage and seafood, shellfish, especially when they are fish from sites near active volcanoes, such as in Hawaii and Iceland, also increases the chance of having thyroid cancer. Chronic elevation of thyroid-stimulating hormone that we call TSH, or having a history of partial thyroidectomy also poses a risk. Common imaging pathway for thyroid cancer are as follows. First, patients with known nodule will undergo clinical assessment like serum TSH testing. Depending the test result, if patient present with some risk factors, an ultrasound and ultrasound guide fine needle aspiration of the suspicious nodule will be requested. On the other hand, if patient does not present with risk factors, depending on the TSH level, If it is under 0.1, viral scintigraphy will be needed. In this case, a cold nodule might represent cancer mass. Therefore, ultrasound will be requested. If patient has high or normal TSH level, an ultrasound will also be requested. Followed by ultrasound, if a solid nodule is found, which may represent a cancer mass, depends on the degree of suspicious feature and the size. Ultrasound guide finding aspiration will be requested. Treatment plans will also differ with different results. As you can see the highlighted part on the yellow section of the picture, they will be referred to specialists for further investigation and management. So, now I will pass on to Yachi for the next part.
In most cases, the initial imaging procedure is ultrasound. Ultrasound is helpful in differentiation of nodule with cysts. However, it will distinguish between benign and malignant nodules. MRI have a limited role in the evolution of several diseases. They may be more sensitive than radionuclide picture in the evolution of intrathoracic goiters, especially when the goiters are poorly radiotracer arrayed because they contain minimal amount of functioning tissue. For nodules found to be in the terminant of FNA, nucleic medicine with 99 technetium protectant or 1,2,3 iodine can be helpful. The half-life of 99 technetium protectant is 6 hours. The energy is 149 kg. The effective dose is 0.01 S3 mg/beg and need to scan at 15 to 25 minutes. It is cheap and has a low dose to patient. So uptake of 99 technetium protectant in the cells may be affected by cell medication and by foods or drugs containing iodine. So here's a list of the medications that may affect the uptake of 99 technetium protectant. So patient must be fast for 4 hours before exam, and the dose we use is 185 mg/beg. Patient have to wait 15 to 20 minutes after injection, and the colorimeter used pinhole, and window is 20% energy and centered at 140 K. So celebrate and record dose and time in hot lab before injection. Injection the patient intravenously. Celebrate and record the rest dose. Then take a picture of the empty syringe. Let patient wait 10 to 15 minutes after injection and give patient a cup of water to drink. Let the patient down on the bed, arms by the side and strap up. Ensure patient keep head straight. Place camera head anterior over the patient's neck. Use 5 cm marker and we do anterior marker, anterior, RAO, and LAO picture. A standard view picture will be done if necessary. 123 iodine whole body scan. 123 iodine study is indicated in patients who have residual thyroid cancer after thyroidectomy that shows LD uptake. 1-3-LD may also be indicated for the ablation of residual thyroid tissue after subtotal thyroidectomy for thyroid cancer. Radioiodine is uptaken by normal functioning thyroid tissue and used in the thyroid hormone synthesis. It is also taken up by most thyroid cancer, particularly those which are well differentiated. The 1,2,3-iodine's half-life is 13 hours. The Ng is 159 kg. The effective dose is 0.2 mc per mg. It is expensive and cyclotron produced. It has a good quality Mg. The patient must not be pregnant or breastfeeding. A BHCG test may be required for female patients. The uptake of 1,2,3-iodine must be affected by thyroid medication and by food or drugs with iodine. The thyroxine have to be ceased for a minimum of 5 weeks before scan. Remove the lead from the 1,2,3-iodine lead well. Measure and record the dose and time in the hot lab. Label the 1,2,3-iodine well. Retrieve 2 public cups. Prepare a pair of gloves for patient. The dose is administered orally to patient by the nuclear medicine doctor. Then give patient a cup water to drink. After 20 to 24 hours, start the picture. Let the patient lie on the bed, arm by side and straight up. Do a whole body picture followed by anterior and marker pinhole picture. So here's some examples for 1,2,3-iodine's whole body scan in thyroid cancer patients. In picture A, the whole body scan shows central foci in both superior and inferior aspects of neck, so see pressure for local node mats. The 24-hour uptake in neck is 1.84%. In picture B, the 24-hour uptake is 15.1%. The whole body scan shows a confluent intense foci in the neck, consistent with large thyroid remnants in the neck. In picture C, the whole body scan shows diffusely mild uptake in bilateral chest, those pictures for lung mats. The hybrid imaging with PET-CT in the evolution of a neck mass is generally performed with FDG PET. FDG is normally not taken up by the thyroid gland since free fatty acid is the main source of energy for thyroid function. Diffuse uptake of FDG generally indicates thyroiditis. Forced uptake of FDG in the thyroid gland represents malignancy in 30% or more of cases. FDG PET-CT is not sufficiently accurate to eliminate the need for surgery in patients with a non-diagnostic biopsy. So here's some cases of FDG PET-CT in different types of thyroid cancer. Nuclear medicine therapy uses radiopharmaceutical targeting specific tumor, such as thyroid, lymphomas, or bone mets, delivering radiation to tumor lesions as a part of therapeutic strategy to cure, mitigate, or control the disease. It can be used as on selective targets or throughout the entire body. Iodine 131 is used to treat and monitor thyroid cancer and hyperthyroidism. Any functioning thyroid tissue will trip and organic stable iodine or is radioactive. It can work on detection and ablation of residual functioning cell tissue in differentiated celled cancer. Initial treatment is surgical removal of all cell tissue. The T4 cyst for 4 to 6 weeks and T3 cyst for 1 week before therapy. Patients should keep low iodine diet at least 2 weeks and no iodine medication taking. Kidney function tests should be done before the test. If patients during breastfeeding, how to see stage 6 weeks. Administer ablative dose of 131 iodine 3.5 to 7 gig. Patient should in hospital and isolated for 3 days or until the radiation level less than 25 mSv per hour. Patient must keep distance with people at least 1 meter. Patient have to travel alone and no public transport use. Patient should drink 1 glass of water per hour in first day, empty bladder without holding. Patient should double flush and wash hand after toilet. Patient should cook, eat, and wash clothing and sleep alone. Patient should avoid events, young children, and pregnant women. The partial or hemispherectomy should be used on treatment of celled cancer. Only the affected lobe or section of the cell is removed. This is usually performed if the cancer is small and the other lobe of the cell looks normal on ultrasound. If the celled cancer has spread to nearby lymph nodes, the lymph nodes removed should be used. Many people who have a partial thyroidectomy won't need a thyroid hormone replacement therapy because the remaining lobe will continue to make enough hormones. After the whole therapy is removed, patient's body will no longer produce the hormones that maintain metabolism. Patient will be prescribed a hormone tablet to replace T4. Patient will usually start taking hormone replacement tablets while in hospital recovering from a surgery and need to take hormone tablets every day for the rest of patient life. Targeted therapy drugs can get inside cancer cells and block certain enzymes that tell the cancer cell to grow. The most common type of targeted cell drugs used for cell cancer are TKIs. These drugs block the function of a group of enzymes called tyrosine kinase, which tell cancer cell to grow, multiply, and spread. If patients have advanced celled cancer that hasn't responded to radioactive iodine treatment, patient may be treated with KTI called Lenvit. External beam radiation therapy, also known as radiotherapy, is the use of high-energy X-ray or electron beams to kill or damage cancer cells. Radiation is delivered precisely to the affected area, which reduces treatment time and side effects. Chemotherapy and palliative treatment could use cell cancer treatment. Chemotherapy is the use of drugs to kill or slow the growth of the cancer cell. While chemo is not often used to treat cell cancer, it may sometimes be used to treat advanced cell cancer which is not responding to radioactive iodine treatment. It may also be used to treat anaplastic cell cancer. Palliative treatment aim to relieve symptoms and improve people's quality of life without trying to cure the disease. It may be beneficial for people at any stage of advanced cell cancer.